So to kick us off, Dr. Cameron, I wanted to ask you, you've been practicing a really long time, working with Lyme and other tick-borne disease patients. What differences or changes have you noted in patients throughout your years of practice? Are patients becoming more complex, or have they always been this way? Can you give us kind of the history of patients from when you started to now?
Well, I think many of the things I saw in 1987 are there. I just have a better understanding of how we got those symptoms. So if I look back to 1987, I had three that were quite sick, not doing well. And at that point, I used to be a geriatric doctor, and I'm used to taking time out for geriatric issues. But it took endless amount of hours with those first three, really getting to know them and getting to know the literature, working with colleagues, sometimes even simple things like one patient I sent up to Dr. Steer. And at that point he said, well, why don't you try amoxicillin instead of doxycycline? So, that first patient, the first consultant said, try that. It shows you how far we've gone. And if it wasn't even clear what to take past doxycycline. So I had, for the next 3 years, been very involved in the patient community, the support group leaders, as well as doctors. And so, it was something I would have liked to publish because I'm an epidemiologist and an internist. But 1990, a paper came out in the New England Journal of Medicine with Dr. Steer and a bunch of his colleagues, where they talked about neurologic Lyme disease. And all of a sudden is that everything I've been observing for those first 3 years was right there. New England Journal of Medicine, great authors, even Steer being the noted for a lot of their groundwork on Lyme, said, hey, these are the symptoms. And they've been sick for up to 14 years with these kind of problems. So that kind of supported what I was seeing, which is you could be sick for years. There was also this list of symptoms, that right now I know a lot more about actually how they come about. But the top symptoms were fatigue, sleep problems, concentration issues, and numbness in hands and feet, joint pain. I could go on and on, which we'll get into later, but it was the same list of symptoms. And so many of them have the same symptoms that they had decided, well, maybe they should do some treatment. And this was a treatment where they thought they would try intravenous Rocephin, which is also called ceftriaxone. And some people weren't getting better, but they were only giving 2 weeks of ceftriaxone. And some of them relapsed, about a third of them relapsed. And so, that's what I would say. It was just nice to see it on paper. And they also mentioned something that I could paraphrase is they weren't sure they were eradicating the organism. So I used that paper, and one of the key papers to start with is it validated my observations, and it's right there. And I thought, boy, that validates what I'm doing, and I'm going to be enjoying further papers. But it turned out that there was controversy ever since that paper came out. So I just wanted to mention where I was. I was young then, and that was there 32 years ago. And so then I was going to elaborate more on what I've learned over the years.
Yes, I would like to hear about more of that, including what are the most common co-infections that you're seeing with Lyme in your patients, especially with the poor reliability of most of our laboratory testing. How are you determining what patient has what and where you go from there?
Well, back in that original 1990 paper, they only talked about Lyme disease. They weren't talking about any of the other infections that we have found that are in a tick. And I think the CDC says, in the last couple of years, they had a list of 17 different infections in a tick. But the ones that we know about the most were Ehrlichia initially. And just when you think you're getting the word Ehrlichia down, Ehrlichia, they said, oh, well, why don't we call one of the types of Ehrlichia anaplasmosis? So, people tend to fight over names all the time. At least anaplasmosis is easier to remember, but Ehrlichia is tough. So that type of organism, doxycycline and rifampin seem to work for. Now, they never really discussed whether that ever turns chronic. The assumption is that the Lyme is chronic, but the research isn't so clear cut. Then they discovered Babesia, which is a parasite in the red blood cells. And people were first having a bunch of parasites in the red blood cells, and it would break down some red cells. They'd be often in the hospital quite sick, and they may even die. And so that first presentation, a lot of doctors stick with that description. They don't look for all of the other problems. And in fact, they're rather dismissive. They often say it's asymptomatic babesia that you get from that parasite. And so anytime you say I'm sick, they always say, oh, isn't that the asymptomatic babesia that I hear about or read about? But I find that parasite is much more common than you think. And often the treatment is so different from Lyme. There's something that's used for malaria called atovaquone. It's marketed under Mapron or the pill form, which is Malarone. Mm-hmm. And that parasite, often explains in my patients where the doxycycline or amoxicillin is not working. So I used to put off the treatment for quite a while, say, well, Babesia wasn't discovered. Well, why don't I just put that off a little bit, kick it down the road? But I've been finding that if someone's tough, very quickly in their treatment, I'll add Babesia treatment. And then the other thing is that people often come to me from all over the country saying, what am I missing? And you'd be surprised how often that doctors are pretty good at some of the other infections, but they just don't cross the line and treat for Babesia. And they're missing that opportunity to do something for that bug. And the last one that gets most of the notice is a hot subject called Bartonella. And Bartonella was best known because it was on the mites on cats. And not just the mites, it's the mites poo. The cat scratches that poo into you. And so doctors have always known it as cat scratch fever because there's a bunch of skin infections. But over time, it seems to pop up in people who have never had cat scratch fever that they're aware of. And so, there's always a pushback from doctors. Like Dr. Wormser said, not a big fan of treating Bartonella unless I get a study where somebody's never seen a cat, never been around cats. I only want to hear about research and it's hard to find anybody that hasn't been around a cat. Even Jody knows cats pretty well. Monica, do you have a cat?
I've had cats my whole life. Yep.
Oh yeah. So that's why I always say, well, it doesn't matter if you have a cat or don't have a cat, is that if you think Bartonella is an issue, it may have been related to the cat. So there's been a fair amount of work in this murky area of Bartonella. And, since the local labs aren't so good, that some people go to Galaxy Lab, they're trying to find some better tests for Bartonella. But we do learn from cat scratch fever that there's like 4 different antibiotics that are commonly used for Bartonella. Doxycycline that we know from Lyme, Zithromax we know from Lyme, but there's also 2 drugs, one called Bactrim, which is a sulfa drug, and rifampin, which is, we know a little bit because it's used for Ehrlichia. So all of a sudden, when we look at what the organisms there are, is that what's emerged that there's complexities of diagnosis and there's complexities on treatment. I was just giving an idea that the treatment that we do depends on what we think is in a tick, what we think is in our area. And just when they say, oh, that bug is only here and it's not there, that as they study it, they realize, oh, the ticks are in Ohio. They thought they weren't there. The ticks are some other place. And just when they say, well, we don't have that bug in the tick, then they say, oh, well, we do have that here, because there's 3,000 counties in America, and there's not enough specialists looking at every county for us to be sure. And just when we think we got it figured out, then the birds move it around. The birds pick it up, and all of a sudden Canada's got plenty of tick issues and plenty of those infections. And then you go to the southern United States. It's weird is that the ticks tend to be smart. They don't sit in a hot summer day in Texas, maybe when it's wet or a little cooler in the winter, but they find ticks, but they're kind of, if they go down to summer, they find these ticks are hiding a little deeper in the infrastructure of grass. So that's a long answer to that. What are these bugs that we're commonly run into in my practice?
Yeah. Well, you touched on Babesia, and I had a question about Babesia. At least two, we know more identified species. Are you seeing much in the way of Babesia duncani on the East Coast? And if so, even if it's patients from another state that are ending up with this bug, are you treating that differently than Microti?
A good question. Whenever they discover something like Babesia microti, then the assumption is, oh, there's nothing else. And that's what the East Coast finding. And the West Coast said, no, there's more of Babesia duncani. So then doctors that haven't quite got it figured out that there are other ticks of both types, so we see duncani out here in the East Coast where I'm practicing. Now, because I'm in New York, it's a weird place in that they don't allow a lot of tests to be approved in New York.
Right.
So the duncani, I can't order from like Hygienics, who's one of your sponsors,
Right.
because of New York. And so therefore, a lot of my patients are from the Northeast or all over the country who come in with the Babesia duncani blood test. And they're not all from the West. And so I suspect that Babesia is an issue of not just that species. And if you look at the world literature, there's Babesia all over the world, but they're not all the same types. In fact, I think there was some lions in South Africa who were mad at their spouse and killing them and eating them. And so they finally caught one that hadn't quite eaten their spouse, and they got the animal and found out that they had the ticks that you typically see Babesia in, and they had Babesia in those ticks. So they thought, and they wrote up a journal article that Babesia is in places you wouldn't expect, and it can have consequences. So that's why the Babesia is emerging. I also can say Babesia is in the blood supply. It's the only one that ends up in the blood supply. And so there's a couple articles that I've been blogging on and writing about. One are this baby at Yale in NICU, neonatal intensive care unit, who ended up having Babesia. They said, well, they haven't even left the hospital. How can they get Babesia? And the mother had Lyme in their third trimester and did well. The baby did well. The baby was born. Then later on, this let me get my two. Sorry, I'm going to start over again, because there were two cases. The Yale one is that's where they found out where that blood came from. They went to this kid, his 20-some-year-old kid, and found out they didn't know they were sick. They donated blood. And it ended up in three babies in Yale ended up with babesia. So they're able to show how this person was not sick at all, donated blood, and now 3 babies in the NICU got babesia.
Right.
And the other one that I was overlapped with was this 2 women who delivered a baby. The baby went home, and they ended up coming down with babesia weeks after the mom got the Lyme rash. And so it's starting to get confusing, not just in blood issues, but it also gets confusing if in pregnancy, because they can't treat babesia if somebody's pregnant. And if mom gets a Lyme rash, and there's always that worry, is there going to be babesia in the mother, and will the babesia go on to the baby? But it just shows you that as far as I've been in my practice 35 years, is that there's still uncertainty, still challenges.
Are you seeing more congenital transmissions with your patients, whether it be Lyme, babesia, anaplasmosis, tick-borne relapsing fever? Are you witnessing that as the years go on?
Well, I'm not a gynecologist, so I don't catch
Right.
like these. I don't know how often a pregnant woman gets Lyme and how often there's troubles.
Okay.
I also take care of kids that are 12 and up.
Got it.
So I follow it. When I blog, I'm writing about what others have written, but there are just never enough pediatricians who find time in their day to write about these things. So it's rare you can find an article, but you do hear worries about transmission. There was even another article that I wrote about with 2 babies that were under 10 months, and they had gotten Lyme disease, and the assumption is that they got them from pets. And they really weren't out enough, they're not in the yard enough, but and so it's certainly, that's a new infection.
Yeah.
More complicated is that can Lyme get transmitted, and how often does it occur, and more research on co-infections. They go to the baby.
Right. In your experience, I know, like we kind of call people with multiple co-infections as just having Lyme, and yet some of these other infections could be maybe more serious in some people than others. Which one or ones are you finding to be the most difficult to treat? Is it the Lyme itself? Is it Bartonella? Is it babesia? Or does it really vary on the person?
Well, there are some of my colleagues who always blame Bartonella for anything tough. It's severe pain, feet pain, or they'll say the emotional side of it is Bart. But I find knowing what's in a tick is that I can never be sure what in a tick is causing that illness. So I try to back off instead of blaming everything on Bart or Bartonella. Is that what is in that tick, and what could be causing that person's problems. So I approach it one step removed. I don't think there is any clear blood test that can say, oh, this positive test on Bartonella has to be the issue. You can kind of drop every other concern.
Okay. Kind of down another road. What are some of the autoimmune syndromes you've been seeing while you're treating your patients? So somebody may come in with a tick-borne disease or multiple tick-borne diseases, but then that kind of cascade of autoimmune issues. What are the ones that you're seeing, and what are you recommending for these patients?
Well, that's why I said that over time they've kind of clarified a little better of what's going on from a mechanism, what actually is happening in your body.
Yeah.
So the whole immune system seem active, and cytokines are one part of the immune system. So when you hear cytokines, in the whole problem with COVID is that you're aware that lots going on with the immune system. And so it's one of the syndromes that's talked about is this pandas or PANS. You know, they first recognized that people could have neuro and psych issues from strep. So like PANDA, the P stands for pediatric and N is neuropsych and associated with strep. They changed the name to PANS because it's still kids, skilled neuropsych, but it starts showing up in other diseases. And if you go to a conference with PANS people, probably 2/3 of them have a strong history of Lyme. And the PANS papers are reflecting that Lyme can do it. But it's when they come up with what do you look for with PANS, they usually say, oh, it's OCD. They'll say it's also the one that has Tourette's and tics, but that's only because they were looking for something unique. As soon as you have PANS, they have all the other things that happen in Lyme. And I don't tend to use the word autoimmune without complaining, because autoimmune means that it's autonomous, that there's no way to treat it anymore. You just have to live with it. So I always say autoimmune like or impaired immune, overactive immune. And so because I write all the time, I kind of always fuss around with semantics. Because when a doctor hears autoimmune, they'll always say, oh, that's the one you don't have to do anything with. And I think that distracts the doctor from saying, well, could an autonomic issue end up being related to a tick-borne issue? And so that's, I don't think one can really separate the immune system from by itself, because technically Lyme doesn't destroy any organs, feels like it's destroyed. So I don't see people going to the hospital all the time with a bad kidney, a ruined liver. They have serious problems, or it's usually just the whole immune system is so overactive, so out of control that they feel like they're dying or feel like they're lost, impaired, they're the only one. And then, but their whole immune system is the one that's driving them and creating that much troubles.
Yeah, I definitely appreciate your perspective on the autoimmune portion of, something that may have other factors at play that are separate from the autoimmune component of it, or autoimmune-like component of it. So how are you helping the patients that have both? Is it treating just the underlying what's known, whether that be a bacterial or viral component, or are you doing other things in support of these presentations?
Well, I have the luxury of being around for a while, as you know, and I'm in the Northeast for a long time. And given I've been around so long, is that I don't have to do alternative medicine and Lyme. I can take over one part of it. So my focus all the time is on antibiotics and diagnostic issues, on counseling, understanding the issues, picking up what's missed, because and that's so that doesn't mean there aren't a role for alternative. It's just that if I focus on that piece, because of where I live and what I do in practice, I wanted to make sure that I reflect this particular approach. What I found is that with that approach, you'd be surprised how many people get distracted because they get something out of alternative medicine, but the doctor may never get back to an antibiotic. And if they get better, great. If they don't get better, sometimes I'll revisit the issue, revisit it, and say, hey, is that maybe Babesia was never considered. Maybe a different antibiotic might work. I don't get to intravenous near as often as I did in the past because there's so many oral alternatives that are available. Doesn't mean I don't do intravenous, but I'm always like picking over things. Or if they've had intravenous and are still sick, I say, well, where do we begin? There's a lot of popularity of pulse therapy
Mhm.
where people get treated and then they'll go on and off treatment. Over time, I find I'd rather have daily treatment. So sometimes if the pulse therapy doesn't work and somebody's coming in to get my views on the subject, why go down that path anymore? I usually like to go back and say, well, daily will work. Maybe something else might work. And then lastly, on that issue of treatment, is that
Mhm.
people feel that the massive doses, everything at once, is the way to go. And so I have people where they're floored. They can't begin to get anywhere because every day to do something, they get big doses, multiple doses, many things at once. So sometimes I'll have to do really small doses or pediatric doses, one therapy at a time, and add in layers and do some counseling and work with them to try to figure out how they can make it work. Now, that
Yeah.
doesn't mean everybody's that complicated, but with
Okay.
complicated people, I do that. I wear that hat.
Yeah. So you're seeing the pans. You're also seeing POTS as well in a number of your patients.
Yeah, the POTS is there's where I see it, at least how I visualize it, is that the immune system is involved, the autonomic nervous system, which controls automatic things like getting up, changing position.
Mhm.
All the things that you don't think about I always often call them automatic. They're just do it. They just People should be able to get out of bed, stand up, sit up. That autonomic nervous system is off. So that was, usually it was that lightheadedness that's been talked about. But the cardiologists have been picking up the fact that they do have cardiac problems from Lyme. So they have a tilt table where they try to tilt to, and even
Mhm.
the tilt where they try to check your blood pressure and pulse isn't always reliable. So they've even developed more and more treatment for that kind of postural things.
Mhm.
POT stands for positional because it's position. Orthostatic is change in position, and tachycardic means some people get a fast heart rate in syndrome. But there was a group in Texas that said, by the way, they don't all have tachycardic. Sometimes they have blood pressure changes, or they have it,
Mhm.
but it's not clear. You can't clearly define it. So that POTS problem is, since it takes care of automatic things, they often have bowel problems and bladder problems because it seems like the automatic things and the smooth muscles are affected in PANS. So hardly ever do you see a straight PANS with just lightheadedness. In fact, PANS probably is more active in kids. But there was a doctor out here who always worked with kids who said, oh, that their first problem they often present with is stomach troubles. Because the kids aren't very good at sometimes when they're young enough at saying, by the way, mom, I'm fatigued or I'm irritable. And well, if they say they're irritable, mom will say, I knew that. I knew that already. Um, so tell me something new. And so given all those autonomic things, is often you'll see kids with PANS where they have a hard time with antibiotics. They're afraid of taking antibiotics. The parents are afraid they're going to mess up the stomach. And there might be an example that you have to start slower, more methodical than jump in with massive doses.
Okay. I'm going to segue into mast cell activation syndrome. Are you seeing that a lot in your patients? Is there evidence or studies going on that indicate that some of those individuals whose immune systems are confused, you know, that's in relation to their exposure to Lyme or one of the other infections?
Well, I'm having troubles understanding the role of mast cells, of allergies, and those kind of things. So I have more and more people who have that issue. But
Mhm.
if you're having, confusion, I'm certainly having confusion as to what's it all going to mean? So I've had to rely on following people who work with mast cell activation disorder, but I certainly don't have a good handle on it. Other than talking to patients, recognizing that there's issues, I can't say I got an answer for you.
Yeah. Okay. Um, speaking of following, there's been a lot more happening in
Like,
the
by the
last.
way,
Yeah.
my son is coming in. I'm gonna
I
just,
love your sun. It
oh,
gives
you
you a
don't mind? Because it's,
beautiful glow.
oh yeah,
I
okay.
have the same problem in my office
Okay, because
here.
there's on New York is they thought there was no sun in the winter, but we do have sun sometimes.
Yeah. Yeah.
That looks like I got a mask instead of a mask.
It
It's
does.
it's just a fan. It's just a light. Go ahead.
Um, so with everything, kind of progressing, I mean, since the time I got diagnosed and I met you, seems like, Lyme is in the news more. There's more in the way of research happening than had maybe happened in the past. Um, how close do you think we are as patients to having, um, curative treatments for both acute and persistent infections?
Well, I often find that because I've been around the block for a while, is that, I have certainly a lot of fresh new cases in the area where they come sooner, but there's still always a tremendous number where they're what I call picked over. They've done this, they've done that, they've tried, and there's something they're missing. And so it's so I get both the extremes. And so I go to IV maybe 5% of the time, maybe 10 at most. That means most people get to where they want to go with a pill.
Mhm.
Now I realize that I do have some people where they've tried everything you can imagine, and they're still sick. So I certainly have some of them. They're the ones that encourage others to come see me. They're big advocates saying, I know Lyme, I understand Lyme, I've been sick with Lyme. And so they're always pushing for people to get medical attention and steering patients along. So I find there's a certain group that's quite sick and that I know and know very personally, but there's an awful lot of turnover of others. And so I'm always encouraging people who've been suffering with Lyme to recognize, communicate with others, support others, and making sure they get the care they need.
Mhm. And how about the new medicines that are being investigated right now? Like, do you think they're going to be, a positive move forward from, the treatment or the group of people that fail acute treatment with doxycycline, hygromycin, or some of the other oxacillin? Are they coming down the road fast enough for us?
Well, a lot of that research you're talking about is in a test tube.
Yep.
And so and of course that's hard to interpret. So because essentially, even if you put bleach in a test tube, that's going to work too, or
Right.
salt on a slug. So that's why, but it does give us ideas. And so not too many of them are ready for prime time. Several of them, like azacillin, is not really ready yet. The daptomycin, which is an intravenous format, is available, but other than that initial study in a test tube, I'm not completely sure that's going to take off, because it's and then you also get like dapsone from a test tube, and that has some side effects. So each thing that's introduced either is not on the market, or it's there's some uncertainty. So I'm always having to make tough decisions, and just when I make one decision, oh, I think I'm gonna have to change my lights. Coming in my eyes, fine. I can't
Yeah.
see.
No.
Okay, I'm back. So so with those drugs like dapsone, Dr. Horowitz has done some description, but it's even hard to interpret because he does 5 or 6 antibiotics at the same time, and a lot of herbal things, alternative and integrative medicine. And so it's always hard to turn and figure out what to do with dapsone. Then the disulfiram, which is this antabuse thing, has helped in a test tube, but Dr. Ligner in our area has championed trying to use it. Even I think Kindler followed after Ligner and said, well, why don't we try that? So there's been whole support groups around use of antabuse for illness. So one has to start pretty slow.
Yeah.
And some people can't tolerate it, and it's inconsistent. It's like there seems to be some of my patients who've gotten something out of it, and some have not. But most important thing is make sure you start it cautiously if one goes that way. The other thing is that I've seen some people where the doctor starts a dapsone before they do much of anything. They'll go right from doxycycline then to dapsone. And I always say, well, why don't you make sure that you go after the infection first? Because dapsone is not really an antibiotic. Not dapsone, sorry. I mean, antabuse is not a antibiotic, but it's but they jump to antabuse too quick, which is disulfiram. And then I say, well, why don't we back up a little and just see what are other treatment strategies?
Right. Okay. At this point, do you want to discuss your study, your vaccine study, COVID and Lyme study?
Yeah, I'm ready.
Yeah. Do you have a screen to share for that, or do you want to just talk about what your newest findings are showing?
No, I thought I would just do it orally. So
okay.
Should I just start with an overview and then
I think that would be great for our audience. Yes.
Okay, so just to give a little bit of background is that when I was young and just finished medical school, I ended up going, spending a year and getting a master's in public health in the field of epidemiology. So all of a sudden, instead of memorizing a lot of stuff, is that this field of epidemiology goes into, well, how do you get this information? And how do you, if you get information, how do you know what you can count on and not count on? And how do you look it over? And, there's almost always more twists to the plot. So it gives you the tools. So I came out during the AIDS epidemic with that training, but I decided to go down the medicine path instead and geriatric path. So I've always dabbled in epidemiology because I've written about 600 blogs. I've done a paper on 100 people with like 5 bands on a Western blot, like what are the consequences? That paper was interesting because most of the people who had delayed treatment, they weren't complicated illnesses. They were all like, overlooked rashes, or the doctor said, well, the spinal tap had to be positive, or that knee was meniscus tear, it wasn't Lyme. Just a lot of simple stuff. Most of it was simple stuff, but was overlooked. And so I've always pushed for, don't look, it's not as complicated if you just look for simple things, make simple decisions. So when this COVID pandemic came along, is that, we all want to do something. So I decided to brush off my epidemiology background, my work on databases. And I said, well, I know I keep getting asked all the time, what is actually going on? What should I do? What if I get COVID? What if I take the vaccine? Or should I not? So what I did was I worked with an IRB, which is Institutional Review Board, so I could do a protocol that you could publish on, that would protect the participants. I also worked with a new software that allowed one to ask questions. And not only would it ask questions, but you could put it on a phone. And so And so it was easier. So all the data would go right from your head to the database to where I could actually analyze it and run the numbers. I didn't need to have somebody type it all back in. And so then, of course, once I got to know that software, which is a steep learning curve, it took 3 months. Then you got to ask all the questions. There's a lot of questions that people who fill this out have to put up with. Well, they have to be over 12 and they have to have Lyme at least. And after that is like, what do you want to know about Lyme? Well, how long you've been sick, and how long you've been treated, and what were you treated with, and do you think you stayed chronically sick, and what was the diagnostic issue? All these kind of things you kind of ask anyway, but I had to ask in a formal way. And then with COVID, there's another set of questions like, how were you diagnosed? Like swab or blood test, and if you were hospitalized, was it in the hospital? And were you on oxygen? Or were you at home? Did you end up with long COVID, pneumonia? How often you got it? And then with the vaccine, which vaccine was given the most troubles, and how bad were those troubles? And so it's just an endless amount of questions of, did you end up having any side effects of it? How long did the side effects last? So it ended up being a great database. But fortunately, over 1,100, 1,100 people were kind enough to share their experience and go through all those questions, most of the time on their iPhone or a Samsung. And so it started in July, but already I've been running the numbers since that time and presenting some of the numbers. But I wanted to give you like a little bit of back room type of how I got to that spot, because to me, you could tell I'm excited about being able to do something and use my background in a novel way, which is time efficient. So it's in nuts and bolts, but I just thought I'd share it with you.
I appreciate it. So with your study, gosh, I have so many questions, but I'll start here. I know that you treat each patient as an individual. However, are there individuals, based on the feedback from your study or in your firsthand experience with individuals that you would not recommend vaccination for?
Well, I've taken the vaccine, so I'm in that group that takes vaccines.
Uh-huh.
Well, I don't like all vaccines. There's always a few that I'm always like, I don't know. But so therefore, and because I'm living with people who've had COVID, I see them in my practice. They've had Lyme and then COVID. To me, that risk of hospitalizations, risk of long COVID is so great that I, have been supportive. It's just that I also have plenty of patients where they don't lean that way. They're reluctant to take it. They know somebody has had some troubles. They're worried about side effects. So this database was to try to at least put numbers, not my opinion, not my where my bent is. Oh, I'm telling you where my bent tends to be, but what are the numbers? So I wanted to go through a little bit of what the numbers tell me.
Perfect.
Okay. So of the 1,100, almost 300 of them had COVID at the time they filled out the survey. So that was a pretty sizable number to already have COVID. So, I was looking at these 30 questions. It's a questionnaire called the Burden of Lyme Disease, developed at Columbia. So I already knew that they were really sick on that questionnaire. They were awfully sick anyway, which I think people with Lyme know there's an awful lot of sick people out there. So when you take somebody that's quite sick and get COVID, they were even sicker. The whole average went up. And that's just averages. That's epidemiology stuff. And then you drill down to individuals. And there were some pretty quite sick people who had COVID. So the conclusion of it is that, yes, you can be sicker. And yes, you can get in the hospital, not all the time. It's like maybe 6%, but it still happens. And yes, you can get long COVID. Like 1 out of 5 develop long COVID. So if you already have Lyme and you already have chronic Lyme and you already have trouble with Lyme, and they're telling you you have long COVID, is that something to look for? Is if one looks at, well, what are the risk of COVID? There's plenty. And so then when you say, well, risk, then you say, well, what are the risks of the vaccine? I always say, but there are also risk of getting COVID too, that you can't always stay in a bubble forever. The Omicron reminded people, that variant, that people who thought they were in a bubble that never going to get it, quite a few of them got it eventually. And these study, when I'm talking about is pre-Omicron. So people who didn't have the COVID, some of them got it anyway. So back to that stats, you shouldn't get COVID. You don't want it because of the hospitalizations, the risk of long COVID, the risk of getting worse. So then you say, well, what are the consequences if I take the vaccine? So as with any vaccine, is that most of them got some side effects, like a soreness in the arm. If you say, was there anything? There's a soreness, an ache, or kind of feeling like tired. Those were the top symptoms. And most of those are gone in 2 to 3 days. So with any vaccine, if you say, was there anything? Yes. Then I was looking at, well, is there anything that lasts more than 3 days? Because that's the ones that are important to me.
Right.
And so there were some that had symptoms, a fair amount of symptoms. I don't know the numbers right in front of me, but for the analysis, I was looking at who had severe symptoms that lasted more than 3 days. With Lyme patients, mild to moderate might be important, but I was looking at the severe ones, and there were like about 25. There's 600 that took the vaccine, and there were 25 that had severe symptoms, severe problems more than 3 days. And then I was looking at, well, what are they complaining about, and what is it that's important to them? And most of them were the same old symptoms that you see with Lyme all the time. The same fatigue, same lightheadedness, concentration problems, memory problems, and those kind of things. And so there weren't the kind of things you normally hear about in the news, heart disease, renal disease, but when you only have 600 people, you're probably not going to see too many anyway. If you see any, I would have been surprised, but 600 people who had taken the vaccine, there was all of these things that looked a lot like Lyme. One person actually said, oh, I had severe, but then it just lightened up and I was better than when I started. So it almost reminded of a Herxheimer reaction. So it was just, only one is not much, but it's of interest. Somebody else might have improved, but they wouldn't have said severe if they got better. So it gives you an idea that, yes, there's side effects, but not as many severe side effects as I would have thought. So if I'm sitting there with a patient, I can have more data. I'm writing it up now and I'm going to blog on it, so I can give a little more details. But any risk benefit, if somebody asks, a lot of them already have it figured out.
Yeah.
But if they're open to discussion, as they say, well, you have to put together the risk of COVID, but there's risk of the vaccine, and you got to make some decisions on which way to go. And I find that when I run the numbers, at least people who are on the fence for themselves or on their fence with telling others what to do, they'll have a little more to go on during that risk benefits equation. We know benefits are not perfect because there are people who get COVID who've been vaccinated. So it's not like it's 100% successful.
Right.
And Omicron humbled a lot of doctors in saying, oh, well, I guess I thought I was protected, but I wasn't. So there's risk, COVID, risk of vaccine, and benefits are mixed. So that's why I find that I can communicate better with my patients, all this information that patients have shared in this survey.
Yeah. I know when you presented your findings in earlier this year, um, according to the survey findings at the time, participants that had COVID and the vaccine indicated that they had more pain, fatigue, neuropsychiatric, neurological, and viral symptoms. Have you done any more evaluation as to whether they got COVID before the vaccine or the vaccine, um, or vice versa?
Well, it was complicated because the study was done in overlap with the introduction of COVID vaccine. It was done before the Omicron, and so it was getting confusing what came first, and often they would get it was just mixed, and so even the big issue, the big headline is that you shouldn't get Lyme, you shouldn't have Lyme. So that by far the overwhelming problem was Lyme, and so having COVID made it worse. Having COVID and the vaccine were still crappy, but all the nuances, it was hard to, with the data that I have. So I'm trying to get more people to enroll in it, with asking more questions to find out what came first, the chicken or the egg. Did the vaccine come after they were hospitalized, or after this, or after that, or beforehand? Because the things are happening concurrently. I hopefully with future people enrolling in it, I'll get a better sense of what came first. I'd like to really see for sure if you've had the vaccine, for sure, does that change when you get COVID? And that the data is, as well as I can design a study, as well as I've worked on it, it was still hard to anticipate every question that came along. And so as I go along, I keep adding questions that will clarify those issues.
Right. Well, I'm going to ask you a couple tough ones, maybe.
Yeah, bring them on.
Okay. Do you recommend preventative treatments for COVID?
Well, I'm not a fan. In fact, I write a lot of my blogs opposing the 2-doxycycline pill, because
No, for COVID, not for not
oh
for
yeah,
Lyme.
sorry, but that was just
That's
for Lyme.
okay. I can ask that question later.
Yeah. So with COVID is that I can't do much because I'm in New York, so I can't really because they have a lot of rules,
Okay.
and so therefore I don't have any personal experience to be able to offer on it. There's some principles, like most of the drugs, like hydroxychloroquine and ivermectin and zinc and other things that are introduced, is that this process has been going on almost 2 years now. So if one uses it, should you use it continuously for 2 years? So one prevention is to take it ahead of time before you get sick. And the other is to take it, it's called secondary prevention. Should you take it the moment you get sick? And if you take it, should you do the antibody types things? Should you take out the other treatments? So, what I find, it's kind of people tend to do either or. They'll say, I'm going to go down the ivermectin path, zinc path, or I'm going to go and the classic one. So I always think that you might end up with both, as a thought for secondary prevention. Go to the hospital, get the infusion of antibodies type stuff. Okay. So, but yes, I can't offer any personal experience other than it's such a hot subject that you can't get good information anymore on it.
Okay. Well, before we go back to the question you were going to answer, do you have any other information or findings from the survey you'd like to share. And then I want to make sure people know where to find the survey too, if they do wish to participate. What is your target um, pool? How many people are you looking
Well,
for the
well, my
survey?
statistician has already said, well, 1,100 surveys completed is awfully good for what is sophisticated, is complicated, and takes so much time to do.
Okay.
So
Yep.
he said, well, I can do, which I have been able to do a lot with, but the target, I haven't put a target on. I just, every time I can get to a higher level, I can answer more questions. So
Okay.
like, I want to write something up on geriatric COVID, because
Mhm.
200 of that group were over 65. So I want to look at what was special about that group,
Mhm.
so that, I'm encouraging all ages, but I was happy that the 200 already signed up. So I can, the second topic I wanted to get is that 1 out of 5 people with COVID get long hauler or long COVID.
Mhm.
So I'm trying to look, as the data comes in, is what's special about long COVID, and
Mhm.
how do you know what's long COVID and what's Lyme that hasn't resolved, or you have long COVID. Every time you go to the doctor, they'll say, "Oh, that's long COVID." You say, "But doc, I got a rash here with a tick in the middle." Oh, no, that's long COVID. It says here right in the chart that you got long COVID, or they'll keep, every time you walk in the doctor, they'll do a SARS test, and you'll say, "But doc, I'm not here for that. I've already had 3 of them already."
Right.
And so I wanted to do a little more research on long COVID, and how do you look a second time? Like, are some of the long COVIDs finally going back to the doctor and getting looked at for Lyme?
Mhm.
So a bigger database would allow me to drill down to understand all these people who think they have long COVID.
Right. How
And
about in your patient population? Are you finding those that are coming in post-COVID? How are you deciphering post-COVID from potentially a relapse of one of their other infections?
well, I find that patients that I see who get COVID while they're under my care,
Mhm.
that the COVID passes
Mhm.
quicker than the Lyme. So
Okay.
that whenever, they're always calling me or working with me on, well, how bad is my Lyme going to get? How bad is my Lyme going to get if I get the COVID, and how long is it going to take to recover? But they typically land on their feet, and they might still have Lyme issues,
Mhm.
but they haven't lost anything. So
Mhm.
I'm encouraged that it's just that they might still have to deal with their Lyme, and they'll often get back on track with their Lyme.
Okay.
And so I tell them, don't get lost in the shuffle of the long COVID. These are the ones I see. The survey tends to be a broad range of patients where
Yeah.
I'm not the doctor, and therefore if the doctor says long COVID, I have more of an interest in, well, should they revisit the issue?
Mhm.
And should those patients who have that look again at Lyme?
Mhm. Okay. Um, Then before we open it up to some additional questions, um, why don't we have you answer the question that you were going to answer regarding preventative for Lyme disease? I know your stance, but it'd be great to hear that out loud.
Well, I'm going to add one more thing on my wish list.
Sure.
Uh, I mean, there's plenty of things on the wish list. It's like, if you already have psych issues, what happens with COVID when you get
Mhm.
it, or what happens with the vaccine when you get it. But the one group that really stands out is that pediatric COVID. So I have 20 people, 20 kids who have completed the survey, so I can get a little information. And this is 12 years and up.
Mhm.
So it would be so wonderful if if you know a child who's had Lyme, whether they had COVID or not, vaccine or not, it would help a great deal to understand Lyme without COVID.
Mhm.
And then I can compare it without COVID with those with COVID, and
Mhm.
understand the role of pediatric issues.
Okay.
What about pens? What about pandas, the pots, and and COVID? When they have COVID, and so that Lyme and COVID, I don't think are going to go well. I've had one kid that did poorly. In fact, there's more than one who did poorly, but some of them are doing poorly on Lyme itself. And then the future on my wish list is that nobody studied kids under 12
Mm-hmm.
in any detail. So the next time I write up the protocol, I'm trying to figure out how to get down into the younger age ranges where the parent tends to be the observer. But what can
Okay.
we understand about Lyme itself in 6-year-olds?
Right.
And what if a 6-year-old gets a vaccine for COVID or Lyme and COVID? So there's I'm hoping to drill down better to understand the pediatric issues of Lyme and pediatric with COVID.
Okay. So you're needing more survey participants or parents of kids between 12 and 18 right now?
Right now, I can take any parent that has a 12-year-old, a 13, any way up. The kid tends to sign what they call assent. That means they sign once saying they agree that it's a reasonable thing to do. Then one of the parents signs a consent, which says, I give authority to fill out this form. But the kid knows how to fill it out a lot better than the parent, because they're used to filling out surveys. So it's don't be afraid of the survey for them understanding it, because they got it.
And privacy is protected.
The institutional review board lets me do these research, and because they're very meticulous about privacy and anonymity, and also the medical journals let me publish this material. I can also do a case reports, which is drilling down to the individual. So when I do some blogs, I'm going to have 4 blogs coming up in the next couple of weeks. Then I can get into individual cases, and then instead of all these numbers that I'm throwing around today, is I can talk about a kid who's had COVID and Lyme. What are their symptoms? Have they been treated in the past? How long they've been treated? All those things. So you really get to know the person. Then when it's all done, what does the data show? So I find that's called qualitative research. You look at the quality of the illness rather than just a bunch of numbers.
Right. And I read your blogs all the time. They're incredibly informative. You go deep to the root of the papers that you're reviewing or the research that you're looking at. And I'm truly appreciative of the work that you do, Dr. Cameron.
Yeah, it's always easy to interpret somebody else's work, but this one is I'm going to combine the data with looking exactly at cases, and so I'm going to do a kind of a webinar type thing and embed that in my blog, so that one can not only look at the numbers, but really try to imagine what that person's going through and understanding it through cases. So it's exciting that I get that this data lets me do those kind of things.
Right. Okay.
Oh, I wanted to answer the question that's been lingering, which is
sure.
what to do with the doxycycline. The original research papers, they didn't show any benefit of taking 2 doxycycline pills. They didn't show benefits of 10. They didn't show anything. But one measly paper came along that said, oh, it did work. 2 doxycycline pills for a tick bite prevented a rash. They didn't look at did it prevent Lyme.
Right.
And also there was one person where they showed that you couldn't get a positive test because you took the doxycycline. So what you need is in that case, you can't be messing around. You need more information. So if I treat a tick, I try to treat the way I would a rash, or I watch. But none of this 2 doxycycline stuff that is out there. And it all came down to the study. It was 8 rashes in the group that had placebo, and 1 rash in the treatment group. So 8 versus 1 was not very impressive anyway. It
Yeah,
was a pretty puny, it was a big study because of how many had tick bites,
right.
but it was still only 8 versus 1 rashes. So that's so tiny. I'm surprised that the doctors picked up on it and all they do is do 2-doxycycline pills without thinking.
Right. Yeah. Well, I knew what your answer was, but I just wanted everybody to be able to hear that. So
Okay.
yeah. Yeah. So Jody, do we have additional questions in the chat that we can start to entertain for Dr. Cameron?
I'm not seeing any questions in the chat that you have not addressed. If anybody does have any questions, please put them in chat now. And we will.
I see one that was in chat on it. Atovaquone looks like yellow paint and tastes horrible.
Yeah,
So
there is
I thought
that,
I'd address that one because it's a 1 teaspoon of atovaquone is 750 milligrams,
Mhm.
and you take it twice a day. So it's kind of a thick, looks like road paint
Yep.
goo that, I heard the taste is not bad, but the consistency is weird, and it gets yellow all over your house. And staying out, I've used that a lot. It's the dose they use to fight malaria,
Mhm.
but Malarone came along. It's the same thing in a pill form, except it's 250 milligrams. So the Malarone, when you go travel to prevent malaria, it's the Malarone, not the Mepron. So
Mhm.
what I find is I actually use the pill much more often, and I tell people the pill is great. It's easy to take, easy to pop. It's 1/3 of the price of the Mepron liquid. Also, you don't spill it. It's I can always go up on the dose, but it's a 250 one. And now some people some people tolerate that so well, the Mepron or the Malarone, but some, when they're so sick, they can't do very well. So I take the pediatric dose to start with. So that Malarone is 62.5 milligrams. It's about 1/4 of the Malarone. And so sometimes people who are so sick, you have to start slow. And that's a good example of starting slow. Even doxycycline, sometimes I have to start with 50 milligrams and slow, and then later on they tolerate things better. But slow is always a good start.
Okay, I do see a question popped up here, and keep in mind, everybody that's joined us today, you can ask Dr. Cameron anything about Lyme, COVID, or the vaccine study. So keep that in mind. Let me get back to this question. Jane would like to know what your experience is with Lyme patients who also have mold illness.
Well, mold is something that's relatively new. There's such a plethora of tests that are out there, plethora of molds and treatment protocols. And so I've, with so much focus in on Lyme and treatment for Lyme, I've been deferring that issue typically to an alternative medicine. So that's why I can't answer it as well as they would like. I do tell people that when you're sick with Lyme, all of a sudden you're susceptible to a lot of things. Whether it's mast cells, you might be sensitive to gluten, to milk, to barometric pressure. Certainly they're sensitive to stress. And so therefore that instead of only the mold first, if you think there's any chance that Lyme is an important part of it, is that why don't you make sure that the Lyme is also taken care of instead of going to mold first. But that's what I always do, that role. But there are people, certainly have people who are leaning on alternative medicine for that murky area of mold.
Okay, thank you, Dr. Cameron. Another question, this is from Jason. If you see a Lyme patient who has gotten nearly all the way better, but still has lingering cognitive symptoms, do you usually see a certain culprit And then in line with that, are there certain medications that are better for cognitive, I believe, symptoms? Yeah.
Well, I think you get down to individual assessment, because everybody has their favorite thing and what worked for them. Even when you read the internet, everybody has their favorite. This worked and that worked, or this doesn't work, or don't do that, or don't do that. So I always find that it's hard to narrow down what each person's going to respond to, what has worked for them in the past, what they can tolerate, and so it still comes back to an individual assessment. So when it comes to cognitive function, if I can get rid of the illness or get that under control, that helps. But there aren't great treatments for cognitive. Some of the treatments for for dementia have been not so helpful. But once in a while I get someone that likes that, or they'll take Adderall type drugs. The stimulants, though, can sometimes make you more awake, but they don't always help your cognitive function. So it still comes back to one-on-one with the doctor, try to sort out how to improve it and how to get rid of the underlying illness.
Okay. Here's a question from
I've got the
Janet.
next one. Yeah, you got it. Okay.
You got it?
Yeah, I got it.
Okay.
So this is from Janet, and it's, do you tell people to get the attached tick tested? I have tried several things for my 5 infections. I'm thinking of trying Rife. Do you have an opinion on this? So there's 2 parts to our question. The first one is, do you tell people to get the attached tick tested? And then the second one is regarding Rife.
Well, if one gets the tick checked, there are some nuances there, because that tick, in at least in the Northeast, has a whole bunch of different things that are in there. And so if you see something and you get a positive test, you don't know if it got into you. So sometimes half of the ticks have infection, or more than half, and they're showing up in the tick, but it doesn't tell you whether or not it's getting into you. So you might end up in treatment just because you have a positive tick test. Although there's always a role of, you at least know what the range is of what might be in a tick. And then the other thing that happens is they've shown that once a tick gets some blood in it, that interferes with the test. So you might get the situation where you get an engorged tick. It doesn't show a thing because the blood in that tick messes up the test. So when you need it the most, then you're the least likely to get any useful information from it. So given those cautions, I have a lot of people who send it in anyway to get what they get, and then I have to interpret what to do. My biggest decision, of course, is what's their health like and what their history is like. I find that people who've never had Lyme before, they've never been sick for Lyme before, are reluctant to take something. And people who've been burnt, who've had their lives, on hold, they're not likely to just sit on a tick anymore. Even if the ticks doesn't show it when you send it to the lab, they're more likely to say, I think I'm going to take on the risk. Even if it's only 4%, 5% chances, that's kind of great for too great for me. I'm going to take something.
Mm-hmm.
And then do you have an opinion about the Rife? She's saying, I've tried several things for my 5 infections. She's thinking of trying Rife. And do you have an opinion on this?
Yeah, I don't know Rife enough to be able to give any feedback. I certainly have patients who have used it, but they're often using it with so many other things at the same time. Is that, and you'll get reports saying, oh, this worked for me. And then I'll ask questions, and there aren't too many people who take a Rife who haven't tried something else. I've also had people where they say they get worse when they do the Rife. So I say, well, why are you doing the Rife if you get worse? Well, they said, well, if I do it enough times, at some point I get something out of it. So other than feedback of patients, I can't really give any real answer on the Rife machine.
The next question is from Samantha. This is, what is your opinion on MAH therapy, NIV, NAD, and the Myers cocktail? Do you have any other recommendations for this kind of treatment?
Well, right now is that I don't have enough experience with those to give the feedback that they need. So, and whether it's the right thing for that person. Because sometimes these alternative medicines, we don't know if they're working for a tick thing, but they might be working for your health. Because, anybody who's been treated for Lyme, their whole system is off. And so that's why it's hard to tell. I just know there's quite a bit of variability between one person and the next when it comes to what might help.
Thanks, Dr. Cameron. I had a question for you. I know the ILADS guidelines, you were lead author on those. Is there a plan for revision of that anytime soon? Are you going to be a part of that, or is somebody else working on updating those treatment guidelines?
Well, I wrote the first two, the 2004 that got published in a journal, and the 2014, and they appear to be helpful in just at least establishing a standard of care. In the latest Family Practice Journal, they talked mostly about the IDSA, which is the Infectious Disease Society of America guidelines. But they did say in the bottom right-hand corner, right in the bottom, they said, oh, by the way, there's the ILADS treatment guidelines. So that was encouraging that at least it hasn't died. But back to your question is that I had hoped to do the third one, but that there are other things that come along that, including this survey, that pull me away. And so, and also, that I'm not so sure, they've raised the bar on how to get guidelines accepted. Even the IDSA has had troubles getting the guidelines through, and it may be because there's diversity, controversy, complexities that even the IDSA is having trouble with our guidelines.
Okay. Yeah. Let's see, a couple more questions came in. Jody, do you want to take one, or do you want me to go for it?
You take Jason, I'll take the one after Jason.
Okay. Just make sure I have Jason. Okay, so Jason, Dr. Cameron, you mentioned you have patients who use Malarone versus Mepron. Have you seen them be similarly effective? And separately, have you worked with liposomal compounds for oral antibiotics? So two separate questions, one Malarone and Mepron, and the other on liposomal antibiotics.
Well, I've used both. For years, I just used the liquid, 750 milligram per teaspoon. But in recent years, I've been finding that if I start with Malarone, I get what I want, what I was getting from the Mepron. So it doesn't mean I don't go up once in a while. If they're tolerating it and they're willing to put up with the liquid, I use both. It's just that I tend to start with the Malarone, and often, especially if I start earlier, you'd be surprised how often it works. Even people with Duncani, that got a reputation for them being tough. I find that, whenever you get a reputation that Duncani is harder, is that some people don't get around to treating for babesia because they always hurt us a little harder, so they don't go there. Second question is liposomal antibiotics is, most antibiotics are getting into the stomach anyway. I think the liposomal, it tends to be more like for glutathione, because glutathione gets eaten up in the stomach and it doesn't really get in the stomach, and it has to be given intravenously. So liposomal is to try to figure out a creative way to get past the stomach. But liposomal antibiotics, I think that's sort of two separate things. Like intravenous Rocephin, you can't get it with a pill. So, but I haven't heard of liposomal either. It's just that the liposomal is more on the alternative medicine area, trying to be creative.
Okay.
All right. The next one is from, just give me a moment here to scroll up my little thing here from Kim. Did you have any survey participants who got the vax and have Lyme report any added psychiatric symptoms after getting vaxxed? She says, I personally know a few who have experienced the psychosis, delusional ideas, paranoia, etc., and wondering if this is an underreported side effect.
Well, in that case, they were talking about Lyme, the vaccination, but people with Lyme who get COVID also happen to have a lot of those same symptoms. I think most doctors don't get very deep into the psychosis, delusional, or paranoia and psychiatric issues because they just assume it's all that they're functional. That is, they should go to a psychiatrist and work that out. But I think whether you get vaxxed or get the disease is that there isn't near enough attention to the psychiatric issues as one needs. And so that's why what I was trying to get as many people in the survey is that I'll have more people that have these psych issues to be able to describe them, try to get a handle on it.
She has a second part of her question too, asking, have you found better success with continuous use of antibiotics or pulsing?
Well, I'm not a fan of pulsing therapy, even though certainly a lot of my colleagues find it works. They report it works, but I just think that continuous antibiotics or no antibiotics is better than the pulse. The pulse, my concern is that you have to get used to the drug every time you restart it. And also, I'm always afraid that it's going to learn something if I go on and off and on and off. So I guess my experience, I'd prefer to do continuous rather than the pulse. A lot of the pulse therapy research has been more anecdotal and or it's been based on test tube stuff, that if you do the antibiotic in a test tube once a week, that it seems to work. But in people, it might not work as well because you metabolize things. So no to pulse, yes to continuous, from my perspective. But I'm not the only one who has opinions on that subject.
Okay.
I think we did we covered most of what I wanted to say, because it's and I really appreciate the audience hearing out my favorite topic right now, which is this vaccine, because the vaccine is an extra layer of something to look into that I enjoy sharing with my patients.
Really appreciate your talk today, Dr. Cameron. I did have another question come in, if you're willing to entertain, from Samantha. She was diagnosed with Babesia divergens. To your knowledge, is this a more severe type, or do the symptoms not tend to vary based on the strain?
Well, I mentioned earlier in the discussion that there's a fair amount of Babesia that hasn't been studied much. So, divergence doesn't get studied near as much as Duncani Babesia microti. So that's why I don't have enough information to give any feedback on it. Now, even when you get a test that does a lot of extra Babesia tests, each test has its own reliability questions, and they work with one person, not the next, so it's, in other words, is stay tuned for these kind of things as they come in.
Okay, thank you. I don't see any additional questions. If anybody has something, now's the time. Jody, did you have any other questions?
I do not. I did want to let everybody know that this is, as you know, being recorded, and this will be posted on Meetup. I'm getting some questions on that, so I just want to go ahead and do a general announcement. This will be posted on Meetup by Wednesday of next week. So if you RSVP'd, which you all did, you will have access to it.
Okay. And then with that, Dr. Cameron, I want you to have the opportunity for last words.
No, I think Jody and Monica, it was great to work with you, and it was great. It's great to have all this work done out west of me, which is west of the Hudson River, west of Mississippi. I'm from Minnesota originally, but it's great that the leadership that's out there.
Well, I wish we could have brought you out here in person like we did in 2016, I think it was.
Yeah.
2016. Yeah. Enjoyed having you here then and now. And I do want to make sure that everybody knows how to find you too. So it's DanielCameronMD.com. Yep, DanielCameronMD.com. You can access the survey there. You can find Dr. Cameron's blogs and podcasts and information. Your webpage is really wonderful for patient resource, whether they see you as the doctor or not. So thank you for that. And thank you for your time today. And lastly, just wanted to again thank all of our community partners for supporting us and hosting these events as often as we can. Anything, Jody?
No, just thank you all for your time today. And thank you, Dr. Cameron, for the presentation and the information that you have shared with us. Very much appreciated.
Thank you.
Thank you, everyone. I hope you have a good Sunday.
Enjoy, everybody. Enjoy this warm weather. Bye-bye.